So we'll shift the gear now to the total full slides of echo images or echo clips. So we'll wait for the slides. So I see a very strict timer. So if you find me jumping to the last slide, you'll know that I'd still have few. But anyway, so I see people are awake now. So our talk today is going to be about how you're going to screen and analyze the tricuspid valve for the percutaneous repair. So my name is Ahmed Bafadel. I help managing the Echo Lab, and I direct the structural imaging program at Cleveland Clinic, Abu Dhabi. I have no disclosure for this talk. Our objective here in the next 10 minutes to know how we analyze the tricuspid valve to understand the valve leaflet challenges and the mechanism of the jet. So I divided my talk into sections, so we can go through it quickly. Last night I found that this session is going to be in the morning, so I added imaging tips, which if you find this sign, the cool cat, then you pay attention to a good tip that would going to help you in imaging the tricuspid valve. So first of all, we need to understand that the tricuspid valve, not as we knew it from the medical school, a tri-leaflet. Now we can see with the advances in 3D, advances in the TEE images, now we understand that the tricuspid valve could be 4 leaflet, 2 leaflet, or even 5 leaflets. And you can see the percentages here on the images. So here just to show you on real images what I am talking about. So basically 4 leaflet, let me put the laser pointer.
It's right.
Okay, so here, no, it's okay, you can show it. Okay, perfect. So here we can see this is the unfast view, this is the septum, this is the septal leaflet, anterior leaflet. Here in this case, the posterior leaflet is divided into posterior piece or segment or leaflet, and we can call it lateral leaflet, and you can see it in the 2D here, and the coaptation and dentation, or we can call it clifting between the leaflet. Here is the 2 leaflet image showing you that actually you can have this in a quarter of the patient. But what I found in these cases, if you have a pacemaker for the EP guys in the group here, those leaflet, I found it when I do a TE that they have more TR when the leads or the ICD coil holding one of the leaflet to the side. This is when you have more TR on those patients. So as we know, the TR mostly is functional. It started usually from the left side to right side, but if you have a progressive TR started with mild to moderate, increases to moderate, then you have RV dilatation, then the cascade started to have more tethering and more pulmonary hypertension. So if you follow the tricuspid community, you'll see that now even the severe tricuspid are not enough to classify, and now the community is adding massive and torrential based on the ERO and the 3D vena contracta, because this will affect the prognosis and the future management plan. So now we'll just apply our knowledge to a case to be more understandable. Our case here is a lady, 65-year-old, referred to valve clinic with multiple admission and presentation with anasarca and recurrent ascites. I showed this to show, I took a screenshot with multiple paracentesis multiple times under medicine. So she sent to cardiology and she was found to have severe TR, and now all the eyes went to the TR causing the ascites rather than the congested liver. So now we'll do the images. So when you start, you're looking at your tricuspid valve. Keep the basics from the MR assessment, the ERO, the 3D, the jet width, jet timing, jet area, all these basics, you apply it to tricuspid. Then we do now the specific thing in tricuspid. So my first way to assess tricuspid, this is a transthoracic, to look at the left side. Left side tells you more about the right side afterwards. So if you have your left side looking good, you don't have MR, the valve on the left sides are all good, then you move to the right side. Just for sake of time, we're going to jump to the specific images. So this is long axis view of the tricuspid valve, showing severe TR, wide jet here, and also the jet touching the back wall of the RA. Here, just to have a better understanding of the tricuspid valve in this view, If your sonographer tilts the probe a bit to see the coronary sinus, then you will have your septal and anterior leaflet on the view. If you have no left side or any coronary side looking, only anterior wall and posterior wall, then you can know mostly that your anterior and posterior leaflet on the view. This will help you much if you're reading more endocarditis and you're looking at like vegetation and things on the valves. Here, in short axis view of the aortic valve, you can see here let me put it here. So you can see in this segment that sometimes we segmented the septal leaflet, and there is almost like a small piece in the middle. Most likely you're cutting the anterior leaflet and posterior leaflet in this view. Then you adjust your PISA and your Nyquist limit to see if you want to do PISA on transthoracic. Here, what I want to show here is the TEER signal. The more triangular signal you have is more severe. Even sometimes you shouldn't see turbulence if the jet is wide open. If you have the valve eaten up or wide open jet, you see more triangular. So one of the trick actually here I can show you, if you have your tricuspid flow here, the E prime flow, more than 65, or let's say around more than 60, you're 80% confident, most of the observational study, 80% confident you have severe TR, even if you don't see the whole jet, even if it was eccentric. So our sonographer here wanted to show the left and right side, how the sizes, the both jet. Here you can see the size of the RV almost like 1.5 of the LV side. IVC, you can see how the jet going inside, non-collapsible IVC. The color showing you all the jet, but here I want to show you here. Here, that patient, when we scanned him, it went to, you can see the hepatic vein reversal, but went to what? A rhythm issue. So here is like 2-to-1 A flutter, and you can see the reversal. So in this view for the images, if you want to comment on the hepatic reversal, hepatic vein systolic reversal, make sure you don't have AV dissociation, you don't have arrhythmia, and you don't have ventricular pacing, because that will give you a fake hepatic vein reversal. So here another cool cat tip. So on your X5 simple transthoracic images, you can get 3D actually. And actually it's not bad 3D. You can get it from both sides. This is the ventricular side, and can tell you this is septal, anterior, and you can have posterior leaflet. This is from the atrial side. And even you can tell that your septal leaflet and anterior leaflet has jet in between in this here. Just a possibility if you want to do it. So TE, where the money is. Before you start the E, keep in mind that some of those patients already dilated their atrium. They have a lot of devices on the left side. So you will face a lot of challenges, because see the shadowing here from the ring here, and you'll have issues from the septum most of the time, shadowing on your septal leaflet. So the TEE, when you do TE, remember that your TE probe is close to the left atrium. So here is the esophagus. You're close to the left atrium and mitral valve. So your tricuspid valve is far on this side. So you'll have sometimes some thinning, shadowing, suboptimal images. Again, you start with the left side screening, nothing on the left side. You have here the severe TR, all the jet, torrential jet hitting the septum, going all the way to the back of the RA. This is here where you start the screening and understanding your valve. This is short axis view at the aortic valve, but then you analyze by your X-plane on the machine. Then you see the leaflet here to see the thickening, gaps, prolapse on those view. You put in the middle, then you see more leaflet of the septal anterior. You go lateral, you get more septal and posterior. So the tip here, one of the tips that if you have shadowing from the septum, so what you need to do in this view, especially the septum is here and you have shadowing on your septal leaflet, what you need to do is push your probe slightly down, and then your shadow will actually come on the aortic valve, and then you can see your tricuspid leaflet. Here then we analyze the color. So the analyze the color in this view is very helpful. Likewise in the mitral, this is commissural view of the tricuspid valve. Then you see how wide is the jet. So here you analyze again your jet, your leaflet length. If you have the color compare option in your machine, then you go all the side of the leaflet. Here it comes the understanding. Another cool cat tip. So if you put your line in between the jet here and you're cutting the papillary muscle of the tricuspid valve, the jet mostly here is going to be between septal and anterior, and the jet on the lateral side is going to be septal and posterior. This is a wide jet. So we know the jet extending from the commissure of the anterior septal to the posterior septal. So we know by this, just one looking at this view, you can divide your eye by seeing the papillary muscle. Tricuspid 3D is an issue sometimes because a thin leaflet, so you don't have maybe better image in 3D. It depends on your setting, but here we can see how wide is the jet as we expected, extending from the commissure to commissure here along the line of the septal leaflet with the other two leaflets. Severe TR, this is very good view just for the images, just to see. This is modified for chamber. You go between 140, 160 to align your tricuspid rigor, especially on the eccentric one here. It comes on this side. But here, when the patient takes a deep breath, you can see the septum goes up. Here, you can have better alignment for respiratory RVSP. Now, the slides is going to cut off. Be prepared, please. So, last few images, we go to the transgastric here to see the left side. Okay, so let's play it.
Can we have 2 minutes, please?
Yeah, 2 minutes. We're going to finish here. So, in the transgastric is, again, a better understanding. You can see the valve both on this view. You see the tricuspid leaflet. But in this view, again, for the people, you're not sure 100%. You're subvalvular or at the tip of the valve. So what you do, one of the tips, actually, you move your X-plane. So you put the heart at 90 degrees. You see the tricuspid leaflets. So you move your cursor or your X-plane to the tip here. So you're sure 100% now you're at the tip of the tricuspid valve. So again here, you can see now the jet is coming between mainly anterior and septal, as we already knew. IVC on TEE actually congested. You can see the color is coming from opposite way. This is the hepatic vein, and I show you clear systolic hepatic vein reversal. Very congested IVC. Left side, nothing on the left side, the mitral, the size of the ventricle, things are looking good. Sometimes you need to finally to screen the RA, any masses, anything abnormal, Chiari networks, anything. This is a prominent ostium, but when you look at it clearly, you want to see it, you can see this actually, what's prominent ostium valve is actually a shelf or a ridge holding all the way to the septum. So you want to come with your clip and go around it so you can keep in mind. So in 2D, it shows as a line, but actually could be a shelf. In multimodality images, we do 4D for leaflet gap if we need, and if you're planning valve and valve, and so we do all the measurement on CT scan. So back to our case, just quickly, I'm not going to present any, just as a closure, because you've been seeing all this. So we put 2 clips for this lady. Very good results. And then the tip here, if you have your middle clip here, if you have this was the last image. So if you have your middle clip, that will give you support for the annulus to close it in. That image will show you the middle clip especially brings in the lateral wall of the RV to closer, even if you have a posterior jet, posterior septal, that closes in sometime, and like in this case. But anyway, that was a couple of last slides. Thank you very much.